I'm gonna start mid-cervical now, around C4, C5, and I'm gonna start gliding down. And I'm gonna see that as I get to her lower neck, are there any findings? Hey everybody, Dr. Todd here from Gonstead Spine and Wellness, and I'm here with Jenna. She is our patient that we're going to go through a cervical spine evaluation, so the neck. So everything you need to know about the neck evaluation that most doctors out there, unfortunately, it's not their fault. They're just not aware of this stuff. So we're gonna share this with you so that you're informed, so you can make great decisions for you and your family. How cool is that? But before we start, if you can just hit the subscribe button, you can share this video with others that you care about, get this information out there. And then in the comment section below, let us know what you want to see more of. And keep in mind, immediately after this video, or on a future video, I should say, we're gonna have another video that after we do this evaluation, we're gonna get into the adjustment, and then we're gonna get into the rehabilitation process of Jenna's neck, because just a spoiler alert, we've already taken x-rays of Jenna and we know she's got some problems in her neck. So we need to fix that. We're gonna show you how this happens. So with that said, let's get rolling. All right, before we get started, I wanna explain what we're even looking for in the first place. So I have a little spine model here, and this is technically the model of the low back of the lumbar spine, but it's the same anatomy, it's the same parts in the neck. And so what we're gonna do, Jenna, is we're gonna go through and we're gonna look for something called a subluxation. And so real quick, I'll just bring you up to speed and everyone else out there watching. This is the front of the spine, back of the spine. You have a bone, disc, bone, nerve in between, spinal cord down the middle. And with trauma, the bones in the spine can shift out of alignment. That can cause swelling and inflammation in the joint, in the disc, and all these ligaments that aren't pictured here in this model, but there's actually 10 ligaments that connect one bone to the next. Those things can swell, get irritated, it can cause a problem to the nerve, and there's all sorts of spine problems, health problems that this can cause. So when we're talking about the neck, it's things like headaches, vertigo, neck pain, spasm, difficulty moving in the neck, numbness, tingling, problems in the shoulder, rotator cuff problems actually, instability problems in the shoulder. The shoulder is the only joint that's completely under stability control from muscles on all these different angles. So when there's a problem with the nerve, it can actually cause muscle problems here, and it can mess up the shoulder. So even the shoulder can be affected from this. So all kinds of things that the neck can really cause if it goes haywire. And so I'm gonna show you how we do the evaluation. Last thing I'll say before we get started is there are different signs of a subluxation. So fortunately, we can find these things on a patient even if they don't tell us, hey, it hurts here. So for example, if a joint subluxates, it gets fixated, it's restricted, it doesn't move properly. So we can move someone around and we can determine through what's called motion palpation if there is fixation in a joint, if a joint is stuck, if it's not moving properly. However, that is the least reliable thing that we can use to find a problem. Meaning, if you had 10 doctors looking at a patient, are they all gonna find the same thing? If you say, let's motion it and see what you think feels stuck, unfortunately, no. That's why that's one of our lowest tier findings, but I figured I would mention that first. One of the top tier, most consistent findings is a difference in temperature on the surface of the skin. So we use a little instrument that measures temperature. If it gives us a reading, it just helps identify at what level of the spine there could be a problem. And it's based on an inflammatory response and how when a nerve is irritated, it actually changes the temperature on the skin. There's all kinds of explanations for that, but just bottom line, it's been used since 1923. It has lots of clinical efficacy. I've been doing this for 18 years now, and I will tell you that I would not give up using an instrument for anything because it helps really get a great starting point. The second thing that is very reliable is edema, which is swelling. It feels like a bruise on an apple, but it's essentially swelling that comes from the joint that dissipates back to the skin. And like I said, bruise on an apple type feeling. That's what I feel as the doctor. Patient sometimes feels tenderness. Sometimes there's tenderness on the actual bony prominence, which is called the spinous process. Sometimes there's tenderness around the whole area. But fortunately with this, Jenna technically could sit here and not tell me anything, and I should be able to find out where I think there's a problem. Doesn't mean that the case history isn't important, Rather the contrary, the case history is very important because that also helps us problem solve. So ultimately, this is a multifaceted approach in that there's lots of different pieces that go into figuring out what to do with a patient. This is the evaluation. I want to know what I need to work on. I don't want to just take someone and say, nice to meet you, 2 minutes later, you're on the table and we're moving bones. We put more emphasis into the evaluation, and then we put a lot of emphasis into the specifics of the biomechanically correct Gonstead adjustment. So with that said, we're gonna start the examination process, the evaluation process. I'm gonna have you flip around facing this direction. So now Jenna is wearing a gown, and the reason that we do this is because we check our patients on the surface of the skin. We have to. There's lots of valuable information that you will lose if you do this through clothes. Granted, we're looking at the neck, but I purposely had Jenna put a gown on for this because to really know what's going on with the neck, you have to check technically the entire spine, but especially up into the upper thoracic spine. So I'm gonna check her from about mid-thoracic up, all the way to the base of the skull. And the first thing that we'll do is we use this little instrument that measures temperature from side to side. If it gives us a reading, it tells us where there could be irritation to a nerve, and we're gonna mark Jenna with a skin marking pencil. I'll grab that over here. Notice in this little bin right here, what I have a bunch of BBs. And the reason we have these BBs is because typically when we see a patient for the first time and we're doing a workup, is when we find a problem, we tape these BBs on the skin with tape such as this. And then when they go on to take an X-ray after we do this evaluation process, the BBs show up like little white dots, and we can correlate our examination findings and the patient's structural findings on X-ray. So it's a very cool and complete way to piece this together because, and this is something that you'll hear us say in a lot of these trainings, we don't find the problem on the X-ray, we find the problem on the patient, and then the X-ray tells us how to best correct it. All right, so with that said, this measures temperature, and the cool thing here, patients really like this because they can be interactive with it. We have a GoPro that's mounted on here so that Jenna can actually watch the process. This instrument is called a Delta T. So this is like Delta T vision. Sometimes if there's little kids in here, it's a fun thing to show them. Like we'll show like their face over here and they can see themselves on the iPad, and it just makes it a little bit more relaxed and fun for them to go through this evaluation process. So what I'm gonna do is I'm gonna start by moving this up the spine this way, and I'll show you what a reading looks like if we find one. I'm gonna have you bend your head down. Okay. And what I'm gonna do is I'm gonna go over the same area multiple times. And I'm looking for a reproducible reading, so we'll typically go over the same area 3, 4, 5 times to see if we see anything. So it's hanging out to the left, and that in and of itself is not necessarily a problem. It's when there's a quick deflection and it happens at a certain level of the spine and it's reproducible. So far it's just pretty much hanging out left. There's a little bit of a flicker up top, not too concerned with it. I'm gonna start mid-cervical now around C4, C5, and I'm gonna start gliding down, and I'm gonna see that as I get to her lower neck, are there any findings? And the important thing with this is not to go too fast. In the cervical spine, it should be done a little bit slower than the rest of the spine. When we get to the thoracic spine and lumbar spine, which is the mid back and low back, we can do it a little faster, and that has to do with just how far apart the vertebrae are, how far apart the nerves and the discs are. So when things are bunched up closer together, like in the neck, with the smallest vertebra in the whole spine, you want to go a little bit slower. Okay. So I'm going to speed it up a little bit. Okay, so now it's starting to come out. And this is a very subtle reading, so this is not a fantastic one to necessarily demonstrate on, but as we get down into this lower neck, this is right about C7 area, which is a very common spot in the neck for there to be a problem. It goes right, and then a little tiny flicker back left. So what we're gonna do, we're gonna go ahead and mark this area right here. That's where I saw a little reading, just tiny little deflection, but it was consistent. I'm gonna keep going down. I'm gonna go about mid-thoracic to see if we see anything in the upper back area. Okay, so this is a little more noteworthy. This is a little easier to visualize. So it pegs right, comes back. So it pegs right, comes back. So we'll make a little another mark right here. I'm going to turn the sensitivity down on this a little bit just to see if that helps me get a better shot of this. Okay, so definitely a reading right here. Let's just go with these two and let's further explain what we look for in the neck. So I'll take this from you. The patient interactive portion is now over, so I took that back from you, Jenna. Okay, and so I'm gonna put your ponytail in your face, sorry. So the first thing I'm gonna do is I have these two readings, now I'm gonna palpate, I'm gonna feel, and I'm checking for motion, for movement. Remember I said that's the least reliable thing? Well, it's the least reliable in some parts of the spine. In the upper cervical spine, I would say it's more reliable, meaning when I find a fixation in the upper neck, it really does help me hone in what's going on. So the first thing I'm doing, I'm palpating on certain landmarks on the upper neck, and I'm laterally bending. So I'm bending to the right, bending to the left, and I'm trying to compare movement from one side to the other, and I'm spanning enough distance that my fingers are covering a couple of vertebrae, so I can feel in between. Does it feel like everything's moving fluidly and congruently, or is there one area that feels like it's restricted? And typically, I like to palpate with my thumb and these fingers. The thumb is actually the least sensitive finger for palpation, so the palpation gurus out there are gonna say never palpate with your thumb. So if you go up and you fact check my palpation skills, you're gonna see that other people maybe criticize that, but this is the groove I've been in for the last 18 years, and this is what's comfortable for me. And then I'm going into extension, and I'm feeling for how these vertebrae, how the spinous processes, which are those little bony prominences that you can feel in the spine, how they close down when I'm extending the neck. They should close down, and almost most importantly, they should flex. They should go forward. So I check an extension, but then I'll also go to neutral and flex, and I'm feeling for separation. Now the cool thing is, and we'll cover this in a future video when we go through Jenna's x-rays, is we took bending x-rays in her neck. So we took what's called a flexion x-ray, where we flexed her head down like this as hard as she can go, and we shot an x-ray sideways so we can visually see that and measure it. And we took an extension x-ray where we extend her all the way back, and we shoot an x-ray, and then we have her neutral x-ray. And there's a lot of information that you can get off of that, but I'm feeling this right now on exam, so I can try to get an unbiased read on what I think's going on prior to looking at the x-ray. And so in this initial workup, because truth be told, we already took x-rays on Jenna, what we did is we went through an exam, we noted everything that we found, marked her up, put BBs on the different spots where we found a problem, and then took the x-rays and then evaluated, analyzed the x-ray, which again, we're gonna go through in a future video. So now, as I get into her lower neck, a common thing that we see with a lot of patients out there, and this is a really important thing to understand, is that the majority of the population out there is going to have more restriction and more problems in the lower cervical, upper thoracic spine, this transitional area. The reason that is because of just the mechanics of how our spine is put together. You have a rib cage here. You have 12 thoracic vertebrae. Each one has a rib. The rib anchors it in place. And then you have a cervical spine. You have 7 cervical vertebrae that don't have ribs. So you have this area that's very flexible and movable, and another area that's very rigid and kind of anchored. And that transition zone where you go from a very movable area to a more anchored area, that transition, which is called the cervical thoracic junction, is a key opportune place for injury to happen when someone has like a whiplash injury, for example, when someone has a slip and fall. So here is the area that typically we will find a problem in the patients that we see. Okay, so let's just contrast that last statement for a second with a lot of chiropractic techniques that take a patient, put them face up on a table, and then twist the neck side to side. They're doing that to affect what's called the facet joint. I don't have a cervical spine model in front of me, but the facet is this more superficial joint. This is, again, in the low back. It's not in the neck, but it's the same type of concept. So it's more of a rotational movement. And usually that's done all throughout the mid-cervical spine because there's lots of areas in here that might be sore and stiff and painful. However, what we found and what we do in the Gonstead method is we want to focus on the primary area of concern, what's causing the problem. So our training tells us to look at typically the lower cervical spine, the most fixated area. So C6, C7, T1, T2, way more common for us to find issues in here and adjust in here than at C5, C4, C3, for example. The way that we adjust, which again, we're gonna show you in a follow-up video, is we're not laying someone face up and twisting the neck side to side, but they're in the seated position or in the prone face down position, and we are setting the vertebra from backward to forward. So from what's called P to A, posterior to anterior, and in the neck specifically, we are lifting and setting that vertebra forward because of the mechanics of what occurs at the disc when the person has that misalignment or that subluxation. Again, we'll go into that in another video. As you can tell, there's a lot of stuff to cover here. There's a lot of content to cover, but let's finish up what's going on with the assessment so you can understand how we assess the cervical spine. So we go through, we motion palpate. I'm then going to be palpating for edema. So I'm feeling for swelling, and I'm going to go into these facet capsules, which is the side part of the neck in here. Oftentimes it can be tender and sore. I might dig a little bit just to elicit some feedback from our patient here, from Jenna. Is it more tender, like up there on the right or there on the left?
Right.
Yeah, and it's much more obvious on the right. So that was kind of a trick question because I already knew what you were going to say. But so right up in there, I would say, something's going on there. I would note that. That's what happens from a joint being irritated, but it doesn't necessarily mean that's where things need to be adjusted. This is all information that we're taking in. We're documenting this and writing down all the different things that we find as we go through the evaluation. So we're checking motion. We're noting that she's more restricted down here. I'm also going to ask if there's any tenderness. There may or may not be. Is that tender at all?
No.
Okay, so that's C7, oftentimes not too tender. Is this tender at all? It's T1.
No.
Okay, T2.
Yes.
Okay, so another little interesting thing is that edema findings, swelling findings, are much more prevalent in the thoracic spine and lumbar spine, less common in the cervical spine. Someone has to be very swollen and acute for them to be tender to the touch or have actual palpable or noticeable edema, that bruise on an apple type of sensation where your finger just falls into the skin. So something you can do at home watching this, take your hand, put it on the upper part of your back and dig in with a good amount of pressure. So you're pushing in on those little bony knobs in the back of your spine and go to each one and don't just push directly into it, push on the side of it, on top of it, on the other side of it, underneath it, pushing up, and really try to elicit to see if there's any tenderness or any pain in there. That is an indication that there could be a problem in that joint for you. Okay? Again, that's just one of the many criteria, but it's something you can do as like a little mini self-assessment. You reach as far back as you can and just start working on that upper thoracic spine, working your way up to see if there's any tenderness. If so, that's a pretty good indication at least something could be going on, and you should probably be assessed like we're doing as well, okay? Now, next part, I'm gonna transition to the upper thoracic spine. I know we said this is a neck assessment, but like I said earlier, we have to really get at least to this upper thoracic spine to have a real handle on the neck, and in all reality, we should really assess the entire spine, but for the sake of this video, we're just keeping it into the neck assessment. So I'm palpating, I'm feeling for edema, and she has a very noticeable dip right here. So as I come down here, it's there, okay? And it just, my finger just sinks in here. I'll compare to the one below. That's a little yucky too. Not as bad, bad. let's just compare and see. I could be right. How's this one?
Not too bad.
Okay, that one?
Worse.
That one?
I would say the one you did last was the
So
worst.
this one in the middle, okay. So there's 2 segments that we found the swelling. We have this reading right here. This one, noticeably, not a whole lot of swelling. Again, what it feels like, bruise on an apple. This one doesn't. This one feels like I'm palpating like an elbow, you know, just like a bony prominence. This is just kind of a squishy feeling. So I'm gonna count down. This is C7, 1, 2, 3, 4, 5. So we got T5. We got C7. Okay, and so at this point, what we would do, preparing for X-ray, is we take these little BBs here. We actually tape a big BB over the area of concern. We always make sure we don't block the spine, so we don't block any anatomy with this little piece of metal that's going to show up in the X-ray. And we put it way off to the side here. The spine's about that wide. This wouldn't be blocking the spine. And we would put one here, we would put one here, and then we would take these smaller BBs, and we would find like moles and freckles and little landmarks. Like there's some freckles out here. We'd tape those. We'd put a piece of tape over that and tape it right on the freckle. When someone has a tattoo, like in this case, we might put one right at the little peak of that one, and then make a note of where we're putting these BBs. So we might put one there, one there, one there. And the reason we do that is for specificity. It's to make sure that when I'm going through and I'm counting and I'm saying, yep, that's T5, I want to make certain that that's T5, because the way that we're going to adjust this is very specific to the segment. I don't want to be on T6. I don't want to be on T4. I want to be on T5 if I'm on T5. So it is a self-check process of making sure that we're on the segment that we think we're on. We then look at the X-ray. We can see where those little dots are. We can identify the vertebra, and we can say, yep, those dots are right at that level. And then I can go to that spot every time I see the patient, because we always have the X-ray pulled up when we check someone before we are about to adjust them. Okay, so there are some other things we look at assessment-wise. We would go through various orthopedic tests. So as far as compressing the head, distracting the head, trying to reproduce any kind of symptoms that they have. We check neurological symptoms as far as to see, are any of the nerves that go into the upper extremities, into the arms, are any of them compromised? Meaning the nerves from the neck control motor control, which is like muscle strength type stuff. So we would check, like I'd say, hey, can you put your arms out to your side? And I would say, hold those up there as high as you can. So actually just both just like this. And I'd push that down and say, hold that down. And I would check to see if one was stronger than the other. That's testing the C5 nerve. And then we'd go over here and I could test like bicep strength. So pull in towards you and then push against tricep. And I would check side by side. So I'm not gonna go through all this right now, but those are things that we do to assess, is there a motor deficit with a nerve? Is there a nerve compression or irritation that's affecting the motor section of a nerve, which is the way that the brain sends signals out to contract and control a muscle. We check reflexes as well. So, we use like a little reflex hammer, and there's a couple of reflexes we check in the upper extremity. And last thing we look for is something called dermatomes, which dermatomes are patches of the skin. We actually have a diagram up over here. They're patches of the skin that are controlled by different spinal levels. So different nerves that come out of the spine control different pathways on the surface of the skin. And if someone has a decreased sensation, increased sensation, so hypersensitivity, hyposensitivity, that's also something that tells us there could be a nerve issue. And then if there's pain. So essentially motor, sensory, or pain finding can help us relay this back to a nerve issue. So that's essentially how we do our cervical spine assessment. And this is one piece because a lot of the assessment comes in the X-ray analysis. But the hands-on assessment, this is where we get started. We usually don't do this in isolation. We go through and check the entire spine. And in a future video, we'll go through and talk about how we look at the rest of the spine. Similar methods. There's some special things we do with the pelvis and lower back that are a little bit different, but I'll keep you in suspense. All right, with that being said, we serve two audiences, keep in mind. So if you are a patient here in the Meridian, Idaho area, anywhere in Idaho, or even nationwide, honestly, even worldwide, we have patients that fly in from all over. Come and see us, give us a call, schedule for us to do a full evaluation with you. We'd love to do that. We serve two audiences. The second one are chiropractors. We teach chiropractors how to integrate their practice with corrective exercise and functional movement. Check out MoveNowU.com. and let us know in the comment section below if you've had a neck assessment, what they've looked for, what they found, questions you may have, symptoms, problems that you're suffering with. Ask us, we'll do our best to answer your questions. We love to serve our community and everyone that's following us. Make sure, if you haven't already, subscribe, share this with someone else that you care about. And I'm Dr. Todd from Gonstead Spine and Wellness. And remember, when it comes to the health of you and your family, results matter most.